Welcome, everyone. Today's workshop, The Truth About Liver Cancer, Unmet Needs in HCC, is produced by Blue Faery, the Adrian Wilson Liver Cancer Association. A nonprofit organization, Blue Faery's mission is to prevent, treat, and cure primary liver cancer, specifically hepatocellular carcinoma, also known as HCC. Remember that, you're going to hear it a lot, through research, education, and advocacy. For those who don't know me, my name is Andrea Wilson Woods, and I'm the president and founder of Blue Faery. I started Blue Faery in memory of my sister, Adrian. When I was 22 years old, I got custody of my younger sister, Adrian, who was 8 years old at the time. I raised her all through my 20s until she was diagnosed with stage 4 HCC 1 month after her 15th birthday. Adrian only lived 147 days with the diagnosis. That was over 20 years ago, and you can read more about our story in my medical memoir, Better Off Bald, A Life in 147 Days. You can also read Adrian's story from her point of view in her book, which is an art journal titled, I'd Rather Be Dead Than Deaf, A Young Woman's Journey with Liver Cancer. And all proceeds of that book go to Blue Faery. I'm really excited about today's workshop. Sponsored by Genentech, today's workshop focuses on unmet needs in HCC. The panelists include 2 liver specialists. We are starting with them today, a patient survivor, and a caregiver who has her own story with cancer as well. And they will discuss the unmet needs in liver cancer, and there are a lot of them. The panel will share their experiences, insights, followed by 2 Q&A sessions, which I'll talk about momentarily. This event is ideal for anyone who has liver disease, is concerned about their liver health, for liver cancer patients, caregivers, providers, or if you just want to learn more about how to advocate for others who have issues with their liver. So let me tell you a little bit about the platform we're on. I'm sure you know it. Ever since COVID, everybody learned Zoom. But Zoom webinars is a little bit different than a Zoom meeting. First of all, if you have a question, please put it in the Q&A. So if you don't see a toolbar on your screen, I want you to take your mouse. It's a little different if you're joining us from your phone, but it does work. But if you're on your computer, take your mouse, kind of glide it over, any toolbar should pop up. And on that toolbar, you will see chat. You are welcome to chat with me and the other panelists, as well as our co-host, Aura Sanchez. She's our program manager, and so she'll be directing any questions you have to the Q&A. You will also see the Q&A. Please put all questions in the Q&A. That way other people can see them and they can even upvote your questions. Since we are having 2 Q&As, if you have questions for our doctors, put those in there and we'll do those first. And then if you have questions later for our patient survivor and caregiver, put them in as there as well. The other thing is you can react. So if someone is saying something that really means a lot to you, you can click the react button. So I see all of you coming in right now. Could you please react? Thank you. I just saw some clapping. Yes, and you can do things like hearts and even surprises. Amazing. Okay, you guys got this. Now, if you raise your hand, Aura, our program manager, is going to lower your hand because we want to put that question in the chat. So I see we already have a question from Michael. Michael, thank you so much. Please put that in the Q&A and not the chat. So we're only going to be looking at the questions that show up in the Q&A, not in the chat, because the chat after a while gets very hard for us to follow. So the other thing is we have an amazing liver cancer community. It's an online HIPAA compliant forum for HCC patients and their families. Aura's going to put that in the chat for you right now, the link to learn more about it. All right, let's get started. We are going to bring our very first panelist to the stage. I know you're going to love him. And he's joining us all the way from Jordan today at the airport. Dr. Maen Abdelrahim is a distinguished gastrointestinal and transplant oncologist, specializing in colorectal cancer, cholangiocarcinoma, and liver malignancies requiring transplantation. He is professor of medicine at the Weill Cornell Medical College and chief of GI medical oncology at Houston Methodist Neal Cancer Center, where he leads clinical trials, including pioneering CAR T therapy for GI cancers. As medical director of the Cockrell Centers for Advanced Therapeutics, he oversees phase 1 trials and develops novel anti-cancer drugs. He's an author of over 300 publications and wrote the first book on transplant oncology, which I already find fascinating. He's an internationally recognized leader advancing research, innovation, and patient outcomes. Dr. Abdelrahim, thank you so much for joining us.
Sure. Thank you for having me, Andrea, and good morning, everyone. Looking forward for a great discussion.
Yes. So as you know, I like people to get to know our experts a little bit better. So tell us, did you always want to be a doctor? How did that path take shape for you?
Yeah, it's interesting. Started back in elementary school. I have my uncle. He's a neurosurgeon, and he always used to visit us, tell us a story about a patient he had interact with, save their life, and a story about managing patients. And then I gained a lot of interest in medicine and diseases. So my journey actually is a little bit different than most of my colleagues in a sense that I started as a pharmacist, where I get to know more about the drug and disease, mechanism of action of a drug. And then I had the opportunity to do a PhD in pharmacology and toxicology, where I did a lot of basic and translational science with the drug discovery in cancer. And even to have a patent on one drug. And then actually, again, even more interest in medicine. I went back and studied medicine. I did my internal medicine residency, then oncology and GI oncology, specialized in liver cancers and general.
Wow, so that is an unusual path. It really is. So let's talk about GI oncology. Why, given how difficult GI cancers are?
GI cancer is a unique solid cancer in a sense that is affecting the GI tract and the organ associated with the GI tract. In a sense, when we have cancer and GI tract or associated organ, usually it's associated with morbidities, life quality again affected because of obstruction in the GI tract, obstruction on bile duct, when there's a cancer in the liver or on the bile duct, or obstruction of pancreatic duct when there's the cancer in the pancreas. And this is associated with pain, or associated with infection, and a lot of intervention that's needed. And I thought, this is a disease group that I can contribute more. I can have a more satisfaction when we treat the disease and have a new drug discovery in the lab and only clinical trials. So it attracted my attention, and since I did my fellowship, I decided to do more of GI oncology focused as far as career and research path.
Well, we're very grateful because I remember a time where I would go to conferences and I would speak to medical students, and they wanted nothing to do with GI. Absolutely, especially GI oncology. They were like, no way. And I had someone actually say to me, no, I'm not going to do that. All the patients die. And she's like, I can't do it. From your perspective, what is unique about hepatocellular carcinoma?
Before talking about hepatocellular carcinoma, what's unique about the liver? The liver is a unique organ in our body, and it can have more than 500 functions, more than vital functions for our body. And so this organ is, when affected by cancer or affected by inflammation, these functions are going to be affected one way or another. And the liver cancer in general, usually most of the cases start by inflammation or fibrosis of the liver, or which is end up like in a cirrhosis, which is one-way ticket of a liver disease. It's not reversible once you reach cirrhosis. And this actually cirrhosis and inflammation create tumorigenesis or carcinogenesis or transformation to cancer, because the liver tried to correct itself, but unable to do so, and by doing so, there's a lot of mutation and can cause cancer. So liver cancer, in a sense, it's unique in a way that this is one of the cancer actually we can diagnose by images. If we have a cirrhotic liver and you have the right images, you don't have to do a biopsy. Just based on the images, based on the cirrhotic liver, you can make a diagnosis for most cases. This also a disease actually that you can cure. Even the disease burden can be affecting multifocal or different part of the liver by transplantation. A few organs can be treated by transplantation, and liver cancer is one of them. This is a disease actually you can prevent or you can screen for by doing in the right setting. You can screen for these high-risk patients by doing an ultrasound or certain markers. So this is a disease preventable, and you can screen for before it happens. So it's a unique. It have a lot of potential for cure, but at the same time, need to be pay attention to details.
So, knowing that, what stages do you typically see your patients? I mean, are you seeing them where they are still within that window of cure?
Some of them, yes, but most or majority of the patients when they come, sometimes they didn't know they have a cirrhosis to start with, and they have a jaundice, and then they have some sort of symptom that lead for them to be going to the hospital, and after that having diagnosis of cancer or diagnosis of cirrhosis initially. So majority of the patient come in an advanced stage, that where the cancer is outside the liver, and in this case usually is not curative. We try to provide some treatment option that can increase survival, control the disease. But for some patients, when the disease in the liver only, and this is where certain criteria, we can downstage them, we can control them till we have a transplantation. And transplantation can be either a life gift from a deceased patient or a living donor from a family member or a friend. So this can be cured if we detect it early, but unfortunately, most cases, it's beyond that cure. But we have treatment options that can have better control.
Yeah, oh, it's definitely come a long way since my sister was diagnosed in 2001. There was just absolutely nothing, especially for stage 4. You not in this moment, but you work in Houston. You're not there at the moment. What are the main drivers of HCC in your part of the world in Texas?
Yeah, the etiology of liver cancer can be categorized in two categories, either viral or non-viral.
Okay.
And even the viral, it depends on the part of the world, which virus is driving the cancer. In Texas, for example, fatty liver or metabolic syndrome, like MASLD or MASH, or previously called NASH, this is actually one of the most common causes for cirrhosis that lead to cancer. It's a multiple step, like fatty liver, ketosis, and then cirrhosis. Alcohol consumption is another major factor. Alcohol consumption that can lead to cirrhosis and insult to the liver, and then cancer. Hep C in Texas and US usually is also another factor. The other part of the world in Asia, it is merely Hep B. So parts of the world affected which viral affected. But alcohol consumption, hepatitis C, and fatty liver, MASLD or MASH is the most common reason for cirrhosis and liver cancer in Texas, and maybe most in US in general as well.
Okay. And if these terms are new, if you're watching, Aura, our program manager, is putting the terms in the chat for you. So don't worry, we've got you covered. Who needs to be screened for HCC? You mentioned screening earlier. So who should be screened?
Well, screening for HCC is those who have a high risk for HCC. And usually, if we find patients who have cirrhosis already, this is a high-risk group and should be like established care with our hepatologist, like a specialist like Dr. Kodali within our panel, with her expertise, they can screen for HCC or liver cancer in a cirrhotic patient who have a high risk, because the screening involves ultrasound, certain markers like alpha-fetoprotein in the blood, and nowadays there's actually other markers that can be used to screen from a blood test. This is not ready for the prime time, but it is coming up in that direction.
Right. And alpha fetoprotein, like you said, it's a blood test, and many people who have HCC, it's AFP for short, it's elevated, the alpha fetoprotein. Um, what would you do to improve the handoff between primary care providers and specialists like you? Because that's where we see, right, huge gaps in especially I'm just because I've heard so many examples in the past month, um, especially with fatty liver. You know, people being told they know they have fatty liver because their primary care physician has told them, but yet they're not referred to a specialist, or they're told not to worry about it. So what can we do to improve that?
Well, it's important actually, and this is start as you mentioned, start from the primary care physician. We do like an annual physical exam, or like maybe sometimes a sick visit to the primary care physician. Once the physician recognizes this liver is not healthy and as a fatty liver, either by hey, a lipid panel is a little bit elevated, or the patient have a high risk with the consumption of alcohol, or maybe have a history of Hep C. So this is the high risk patient. Usually the primary care physician communicate and refer initially to the hepatologist if there's a concern about the liver functionality, LFTs, liver function test or enzyme is elevated. So they start establishing care with the hepatologist who have a depth and the knowledge on the liver disease, and they can screen patient appropriately. So they refer, it's a multidisciplinary approach. And when we work together, we save lives. We can do a better job. Primary care physician, once you recognize there's high-risk patient, there's initial elevation on the enzyme or fatty liver, metabolic syndrome, refer to the hepatologist. Hepatologists do the appropriate screening. Once they find there is a risk or the lesion, like they do the appropriate scan, and if that's confirmed in the right setting to be cancer, refer to the oncologist. Oncologists usually start staging and then come back to the multidisciplinary approach as a tumor board. We have hepatologists, we have oncologists, pathologists, radiation oncologists, intervention radiologists, all to come together, multiple physicians sit and watch each patient and review each patient. So this multidisciplinary approach from these all the experts is the goal is, can we cure it? Is it localized? Can we transplant it? Can it be resected? Can be like can we do like Y9 intervention, which is intervention by interventional radiology. You can do like beads that have radiation or beads that have chemo. Can we do that to cure it? If not, okay, well, we go back to the oncologist. Oncologist, okay, what options available? What new treatment do we have? So this is, as you can see, it is a dynamic and involve multiple physicians and to cure or to manage patients with diagnosis of liver cancer.
I want to call out something you said, because unfortunately, so much of the time, the onus is on the patients and families to advocate for themselves. So if you are told that you have cirrhosis, that you have fatty liver, that you have hepatitis C or hepatitis B, and you are not referred to a hepatologist, demand it. Demand it right away. Ask for it. And if you have any issues with that, then reach out to Blue Faery. It's really important that you see the tumor board that Dr. Abdelrahim just talked about. Where have we made progress, and what gaps do you still see in terms of actually caring and care and drugs, for example?
There have been a tremendous changes in the management of liver cancer, and we live in the era of precision oncology. We live in the era of immunotherapy. So back 10 years ago or 15 years ago, there was like only few drugs to treat liver cancer. It's not chemo. This cancer we didn't treat by chemotherapy. This cancer we treat by targeted therapy, smart therapy called tyrosine kinase inhibitor, TKI. And there's like most of this medication is by mouth, is given and have affect certain target, but have some side effects. But we didn't do much of progress on of managing or improving the outcome, the quality and the survival of those patients. But since the immunotherapy been discovered and been used to treat cancer, liver cancer was one of those cancer that can be treated by immunotherapy. Initially, we treated the second line. We start with the small molecules, TKI, tyrosine kinase inhibitor, then you can use immunotherapy. Then we found out actually we can put immunotherapy in the first line. And immunotherapy doesn't work by itself; it's work in combination. So immunotherapy with target therapy, like a drug that can target blood vessels, or immunotherapy combination that's targeting different pathways in the T cells or the immune cells. So, and actually, some the studies have shown that some trials have shown that 5-year survival actually can be to 20%. That means 1 in every 5 patients can make it to 5 years. This is a new milestone. We never heard about liver cancer make it to 5 years. Now we're talking about 1 in every 5 we can make it to 5 years, and 30% of the patient can make it for 3 years. So this is an exciting time, and we are excited in the GI oncology community and the liver cancer oncologists and hepatologists that we can make a difference. And there's more to come. Some of this combination with the radiation therapy, with Y90, local regional therapy, and immunotherapy. Actually, interesting enough, sometimes after a couple of years in immunotherapy, there's no evidence of cancer, even this is stage 4 cancer. I will not say this is for every patient, but there is some patient after 2 years, we stop the treatment because cancer is gone, and then we can just monitor them, and if it comes back, we can reach out them. So I would say there is hope, and I think we are making progress. It's an exciting time for oncologists to treat SCC.
It really is. We had a live event, in-person event in Dallas 3 weeks ago, and I finally got to meet in person one of our volunteers, and she is now considered a survivor. She was not eligible for transplant. She responded incredibly well to immunotherapy. I mean, it's been a long journey. It hasn't been easy, but she said even her oncologist never expected to say those words to her. And of course, she's going to continue to be monitored, but I mean, it's happening. It is. One last question before we let you go and then bring you back for the Dr. Q&A. What's your final message about improving the unmet needs in HCC?
I would say that, first, try to prevent it if you can. Try to recognize it and reverse it. Some of these cancers, actually, or initial changes in the liver can be reversed before it becomes cirrhotic. Cirrhotic is non-reversible. So recognize it, recognize the risk factors, recognize, communication between physicians. If you can reverse it, do. If not, and the patient diagnosed with cancer, actually, let's go to the centers with a high volume, center of a transplant center that can be cured in a sense in early stage cancers. And then also participate in clinical trials. Clinical trials is the way. The drug that you enjoy now to treat you, there's come after many patients participating in clinical trial and they led to the approval. So I think there is an area of unmet need in this disease. We together can make a difference. Participating in clinical trials, communicating with physicians, work together as a group.
Oh, thank you so much. That's such a great message to end on. Ora, would you put a link to the clinical trials page on Blue Faery's website? Because that has a clinical trial finder tool. It's a custom tool. It's really cool for HCC patients. So we're going to say bye momentarily to Dr. Abdelrahim, and we are going to welcome Dr. Kodali to the stage. Dr. Sudha Kodali, MD, MS, PH, is Associate Professor of Clinical Medicine at Houston Methodist and Adjunct Associate Professor at Texas A&M University. Go Aggies. She serves as Medical Director of the Liver Tumor Program at J.C. Walters Transplant Center and Director of the Hepatocellular Program at Houston Methodist. Her expertise includes transplant hepatology, hepatocellular carcinoma, cholangiocarcinoma, and fatty liver disease. Dr. Kodali received her medical degree in India and completed her gastroenterology and hepatology fellowship at the University of Alabama at Birmingham, right down the street from my house, where she also earned a master's in clinical and translational science. Just a tiny bit of an overachiever, just a little bit. Dr. Kodali, thank you so much for joining us.
It's a pleasure. Thank you so much for having me.
So same question to begin with you. Did you always want to be a doctor?
I did. Right from the time I was, 5 or 6, I thought I should be a physician. And there were several reasons. Of course, I come from a family where there were no physicians to start with.
No.
And through, I guess school and college of 20 some cousins, I was the only one who chose medicine. Everybody else went to become engineers. And then in India, just growing up culturally, physicians are treated with respect and admiration. I saw them as folks or people who could come in and heal and help patients. So I just grew up seeing this. And one of the earliest memories I have is my grandfather had an asthma flare. Asthma runs in my family, and he was, kind of bedbound. And this neighborhood physician that we knew very well came almost close to like the middle of the night, gave him some IV medications, and within 30, 40 minutes, he started feeling better. And that just left a lasting impression. And growing up experiences like that just made me want to really pursue medicine. And my father was very crucial in shaping this and helping me become a physician. So yes. So yeah, as I'm just, I didn't know what else I would do if I did become a doctor. That's how I grew up. So yeah.
No, that's one thing I admire about doctors. I feel like most of you found your purpose very early in life, whereas that's not the case for most people. What made you decide to specialize in liver disease and hepatology? Because it's definitely not the easiest space.
It's not. So in med school, during our rotations, I would see a lot of patients coming in with liver disease, whether it was infectious hepatitis, because hepatitis A is pretty, or at least used to be pretty common back when I was in med school. We would also see patients with alcohol-related liver disease, ascites, jaundice, decompensated patients, and cancer patients. And so I continue to develop this interest because you care for patients, you kind of take care of them, and you sometimes get inclined to that specialty. The other aspect to my interest was because culturally, expectations wise, I think women always chose OBGYN or dermatology or ophthalmology, and areas that were considered to be easier career-wise, so
Mm.
that you could go home and take care of family. And one of my professors actually said that to me during my medicine training, where he's like, "Oh, women should choose like some easier paths," which just made me a little upset and
Yes.
motivated me to pursue a field like gastroenterology, hepatology. But that was not why I chose, GI hepatology. And then throughout residency, I continued to enjoy and continued to feel interested in the area. And then I was lucky enough to get trained at UAB Birmingham, which was still one of the best programs to train for GI. And then I was really fortunate to have faculty members who continued to inspire me, mentor me, and were really crucial to my training in hepatology. So that's my story.
Well, I'm really curious. So, what differences do you see in liver cancer between India, where you started, and where you're from, and in Texas, where you practice now?
Yeah, so my training has all been in the US, but during med school, of course, we do actually 5.5 years of rotations and all, and an internship year. So there, back then, we would see a lot of patients with liver cancer, and mostly from hepatitis B and C. Alcohol was a big part. Over the last 2 decades, the etiology has changed. What we see here in the US is, now metabolic associated liver disease that Dr. Abdelrahim discussed a little bit. We also see alcohol related liver disease. We are not seeing as much infectious hepatitis because we have fantastic drugs to cure hepatitis C. We have medications to control hepatitis B. So the infectious etiologies are not a big issue as much anymore. And the same thing is happening back in India now. I talk to colleagues and friends, and because of convenience foods and westernized lifestyle, alcohol and metabolic liver disease are also the leading cause of liver cancer and liver disease in India as well. So we are seeing this global epidemic of metabolic problems contributing to cirrhosis, decompensation, and liver cancer.
Wow.
Yeah.
Wow. That's so sad. Good about the viral hepatitis, but sad about the fatty
Yeah.
liver.
Yeah.
How do patients usually end up in your care? Because you're the specialist. How do they get to you?
So they come from different sources. So the primary care physicians do refer a lot of patients when they see them for their annual visits. The liver enzymes are elevated, or they see fatty liver on imaging, or they see some incidental findings on imaging that is being done for some other reasons, like a cardiac PET or cardiac testing or something else shows something in the liver. So that's one source of referrals. The community gastroenterologists do refer a lot of patients as well. And then the referrals, at least for where I work, come from community oncologists for patients with liver cancer. So the referral sources are many. We're also seeing a lot of referrals coming from endocrinology because diabetes leads to fatty liver. So that's a shared patient population, I would say. And then, a lot of times, I personally feel there are patients who are out in the community who are actually not referred to us. This could be folks who are kind of stuck with their gastroenterologist and are being told that, oh, it's just a little bit of fat in the liver, keep working on it, till they actually end up with cirrhosis or cancer, and then they're referred pretty late in the game. And then sometimes I see this with the community oncologists, where patients are treated with first, second, third round of everything, third line, I mean, and then they're referred, and it's a little too late, and sometimes they're never referred. So that's the most frustrating and heartbreaking aspect to what I see, where patients are never even told that there's other options and they don't get to see us. So these are missed opportunities in patient care, I think, and we need to work on that.
So from your perspective, what are some of we identified one just now, what are some of the other biggest unmet needs in HCC care?
I think there are many. Of course, lack of awareness, education, patients, providers is a huge unmet need, and we got to go out and talk to providers out in the community about what's out there, the emerging trends in treatment of liver disease, especially cancer, etc. A lot of times in the clinic, we forget to talk about the logistic aspects to patient care, especially in cancer care. In a city like Houston, where we practice, commute is something that we don't ever even talk about. It's a big, big, big deal. Patients may or may not be able to drive. A caregiver may need to take time off and come with them. And sometimes these appointments can be very overwhelming. They're asked to park somewhere, come somewhere. So that aspect is a huge thing. We also don't address sometimes issues like nutrition and psychosocial issues and support, for which, of course, you guys do a fantastic job creating that sense of community, which is extremely important. Caregiver burden is never discussed, at least in the clinical settings that I know of. So I'm trying to, as I do this on a daily basis, on a regular basis, I try to remind myself to talk with the caregiver and say, hey, take care of yourself, call us if you need anything. And then the nurse navigators and again, support groups are extremely helpful. A huge proportion of patients we see from the southern part of Texas, language is a barrier. Oftentimes we feel like having an interpreter service is enough. It's not. Sometimes you have to do a little extra, sit with them and make sure they actually understand everything that's being explained to them. So these are the few key aspects to the patient care and the caregiver that I always consider. And then I think the biggest complaint I have is the community providers not knowing what is out there and not offering all the options to patients is not fair. Patients need to or deserve to know their medical options, if surgery is an option or not, is transplant doable or not? And without that multidisciplinary approach that Dr. Abdelrahim discussed, it's impossible to provide that best overall well-rounded care to patients that can improve their outcomes.
Yes. I have another personal story I won't share. It's in a different cancer, but it just broke my heart because this person in my life only saw the community provider, wouldn't get a second opinion, which I could have easily facilitated. And it just broke my heart. So on that note, is there a particular patient or caregiver who really stands out to you?
Oh, every day. Patients and caregivers are, I feel like it's just amazing, and the grit and the determination and the positivity that you see with when you see patients in the clinic and the caregivers that accompany them, it's just amazing, and sometimes makes me not want to complain about anything at all. Even if you're having a very long day and a bad day, you just want to like be grateful. So yes, there are many, many, many stories I can share, but just last week I saw a patient who always comes with his daughter. He had never seen us before. He was referred by one of our community oncologists for diagnosis of multifocal hepatocellular carcinoma. The patient is not very fluent in English. The daughter has a full-time job, a family of her own, kids who are high school, middle school, so that she needs to do the whole commute, take them here, there, you know how the activities that the kids have. In spite of that, she always shows up with her father. She's always taking notes. She'll ask all questions, make sure she understands everything, follows the instructions like like perfectly. And then after a 40-minute clinic visit, the patient who's her father asks something or says something, she never ever has a sign of of frustration or anything. She's so calm and composed, and I'm always amazed at caregivers when they come and they're just like sitting there and doing everything they can. That kind of dedication is impressive and very, very remarkable, I would say. And then from a patient's perspective, again, same thing, right? So they're dealing with all the side effects, all the complications, the fear, multiple other things that are going in their head, but they just come and they sit and ask questions and follow the recommendations. I had a patient that had been seeing now for 6 years, was diagnosed with liver cancer. We enrolled him in a clinical trial. He had all kinds of side effects that you can imagine: immunotherapy-related hepatitis, skin changes, depigmentation, thyroid issues, diabetes. I mean, the whole everything. Pull up, correct. And he would still show up for his visits. And then we referred him to dermatology, endocrinology, like 4 other specialists, never complained, finished the trial, got transplanted, doing so well right now. But, again, the success is fantastic, but, the determination and the grit and just showing up for each visit with that positive attitude is just inspiring.
Yes. And I love the reactions I'm seeing from people. So please keep them coming. I have 2 more questions for Dr. Kodali. If you have any questions for either one of our physicians, now is the time to put them in the Q&A. And Terri, I promise we're going to get to your question too. I believe as a panelist, you're not able to put in the Q&A, but we will get to it. How do you approach giving patients bad news while maintaining hope?
I think it's probably one of the hardest things to do for providers, going in and wanting to kind of share bad news, whether it's their stage of cancer or a new diagnosis of cancer, because I can't tell you how many times patients just get referred to us and they're told they have a spot in the liver. And when you actually look at the scan and review it in the tumor board, it's not a spot, it's a big cancer, which maybe has metastasized or has vascular invasion. So I think for me, over years, I've learned to walk in with a plan, and I'm always honest and upfront about their diagnosis. I don't try to minimize. I draw and show them where their cancer is located, how big it is. And throughout the clinic, we have all these cartoons and pictures and representation of their liver. It does help because I'm a visual learner, and I think patients appreciate seeing what's going on rather than having to imagine, because it's very complex and overwhelming. So I use that. I also feel that honesty is important. Patients do deserve to really hear about their diagnosis. So providing the accurate information and details of their diagnosis is important, but also going in with reassurance and telling them that we have a plan in place, right? So these are the next steps. This is what we're going to do. You can actually see a surgeon today, and we'll also ask the oncologist to see you. So we go in with that kind of mindset and information, and I think that helps a lot. These visits are not ever easy, but I think going in, keeping it simple and providing clear information and a plan before they leave helps them leave with knowing that it's not the end of the world, and we actually are going to proceed with the next steps, and they get an idea of what to look for and what the expectations are going to be.
All right, as we bring Dr. Abdelrahim back to the stage, what's one final message you want to share about improving care for people with HCC?
So I think the key message is multidisciplinary collaboration and early referral. So sitting out in the community and not knowing your options is not fair for the patients. So being aggressive, being advocates of your own health and asking for referral, second opinion, third opinion is extremely important. And once they get to us, we will review the scans in our weekly multidisciplinary tumor board where there are 16, 20, 25 doctors at a time. We are all specialists that know enough or more than enough about liver disease, but are experts in our own areas. And we come up with a definite plan for the patient, and we see the patients the same day and we give them their recommendations. So that's fantastic. And that helps patients and they know what their options are. As I mentioned, early referral and not waiting for an year or two before everything has just gotten worse is other important part. And then paying attention to the social, the emotional, and caregiver needs is the other aspect that we need to work on a little bit more. And we are doing a lot of work at Houston Methodist in this regard. And by increasing awareness, education, we can give better outcomes to patients is what I believe.
Right. Okay. All right. So thank you for that. We have time for a short Q&A with our doctors. So either this is for either one of you. Is there a risk of seeding during biopsy? And please explain what seeding is. So that is the first question that we have for you. Either one of you can take that.
I can start. I think, seeding in the past used to be an issue, and because for somebody with type of curative. But now seeding is not anymore because the technique is different, and the bath is for biopsy can be internal, so it's not always like going through the skin. And the biopsy itself now is like the technique is different. So I think it's not a concern. And we didn't do biopsy, and Dr. Kodali, maybe she can comment about this as well. We didn't do biopsy for liver cancer unless we are thinking this is a mixed histology or there's not actually in the setting of no cirrhosis of the liver. So we think this might be coming not in a setting of cirrhosis. So the biopsy is not done unless there's a question about diagnosis.
So I'll add a little bit to that. Compared to about 10 years ago, we rarely send patients for biopsies. We use image guidance and we don't do multiple passes. So you kind of go in and you do what is called a targeted biopsy if you're going from outside the abdomen, which is called the transabdominal approach. And what the interventional radiologists do now, in contrast to what we used to do in the past, where we would just go in and take a sample and come out, they actually close the tract with gel foam. So the risk of this, the cancer, disseminating or creating that path is lower or minimized. It's not zero. And we rarely actually see the seeding to be a problem. And then as Dr. Abdelrahim mentioned, there are other ways of doing biopsies where instead of going from outside the abdomen, a GI doctor, we call them advanced endoscopy physicians, they go in from inside with the help of a scope and use smaller caliber needles to take biopsies internally. So the risk of, again, the cancer spreading is much, much lower. But in patients who need biopsies do help determine the exact diagnosis and the therapy that works best for that specific tumor.
I know it's not common now, but I am grateful with my own experience with my sister because she was so young. Like she had every test immediately, and it wasn't even a question. They did a biopsy right away because they were like, "What's going on with this 15-year-old girl? This makes no sense." Whose blood work was normal. That was the other thing that was very confusing for everybody. So we have a lot of questions. I can't get to all of them, so I'm going to do the best I can. But I'm definitely going to do this one because I hear this one a lot. So this is Cheryl's question. What do you think about using milk thistle and the drinks they suggest are good to use? So herbal supplements such as milk thistle. What do you think?
Yeah, so this is a topic that pretty much every clinic visit we go over because it's important, right? So before I go over milk thistle or any other supplements, there's a condition called drug-induced liver injury, where any drug, whether it's prescription or non-prescription, can affect your liver health, can increase your liver enzymes, and 5% of times the numbers may not ever normalize, and about 1 to 2% of those patients may end up requiring a transplant. So it's not something that needs to be taken lightly. Now, prescription medications like antibiotics, everything that we pretty much take, is metabolized by the liver. But specifically talking about over-the-counter supplements, there is some data regarding the benefits of, say, milk thistle or turmeric extracts or, vitamin E capsules or coffee and other things.
Coffee.
But
Yeah,
yeah,
coffee's good, right?
So, but a lot of times, these supplements are not FDA approved.
That's
So
true.
the ingredients, of course, the key ingredient could be milk thistle, but the fillers are what are toxic to the liver. Milk thistle has been studied extensively in rats, and there's definite benefit in rat livers, some benefit in human livers, but compared to what can happen, especially regarding, elevation of the liver enzymes and toxicity, we typically recommend patients from taking any of these supplements that are over the counter. Every year there's a new supplement, ashwagandha, turmeric extract, green tea extract, coffee extract, milk thistle. These are like the 5 to 6 common supplements that patients always ask about, and we tell patients to not take these.
Yeah, I always say when there's a liver cleanse, that's your liver's job. That's your liver's job.
Correct. Yeah. Liver cleanse, liver detox, liver everything. I say, don't drive to a pharmacy after the visit today and pick up any of those. That's what I tell them every time I see a new patient for abnormal labs or new diagnosis of liver disease.
Especially if you have like the cancer diagnosis has been done, and we always ask our patients, don't combine things with treatment. Sometimes they said, oh, I can use this, or I can switch to rescue the liver. Once the diagnosis is done and we start treating with immunotherapy or targeted therapy, we always encourage patients, don't combine with, because that might worsen the function of the liver, as Dr. Kodali mentioned, and even the treatment to drug interaction can happen. So if you are, in a treatment with the oncologist, try not to combine it with anything, because that might affect the efficacy or toxicity of the treatment that you receive.
Yeah, I think it's always important. I always tell patients, always keep an ongoing list of your current meds, supplements, anything, even like what you typically eat, like keep that and have that at all times. So this is for you, Dr. Abdelrahim, from Anna Maria. I think I know the answer, but I want you to answer it. Does the time period of 3 to 5 years apply to liver cancer that is metastatic cancer, such as prior colon cancer? So secondary liver cancer, not primary liver cancer.
So that means you have colon cancer metastasis to the liver.
Right. So
And
she
liver
wants
is
to know
if
that 3 to 5 year applies that you mentioned.
I think interesting question in a sense, that is, if the cancer metastasizes from the colon or the rectum to the liver only, usually liver metastasis from colorectal cancer is associated with a poor prognosis compared to the kidney, compared to the lung or other organs. But the good news for some patients, fit patients, we can transplant patients with liver-only disease. We can take the primary out. We can take the liver and transplant them with the liver that is healthy, not have a cancer. But there's a criteria for it. And for selected patients with stable liver disease, there's certain criteria. But we can treat liver colorectal cancer metastasis. Liver is a poor prognosis compared to lung. But the good news, if it's liver only and stable disease, good biology, certain criteria for fit patient, transplant can be an option, and patient can be cured from stage 4 colorectal cancer with liver-only metastasis for specific patient population.
I know many survivors, or they're living with stage 4 colon cancer as a chronic disease. Let's see. We have time for just one more question. If we don't get to your question, please feel free to email us. You're going to get an email, and we will follow up with you. So let's see. Family member has had progression, struggling with blood count, missing, skipping treatment, turned down for clinical trial. He was put on a pill regimen. Are there any other options for him?
And this is colon cancer or liver cancer?
It's unclear. That is unclear from the question. So
if it is a liver cancer and treated with, usually like on the first line setting with immunotherapy combination, and then is an oral pill, usually tyrosine kinase inhibitor, TKI, like molnupiravir, sorafenib, cabozantinib. Usually, like the way it goes is immunotherapy combination first line, then one TKI after another. You know, we
Right.
started Lenvima, cabozantinib, and sorafenib, Ramo. So there's multiple forms of TKI, and each TKI can give survival and benefit. If it is a colon cancer with liver metastasis, then we select chemotherapy, first line, chemotherapy, second line, chemotherapy, combination third line, or certain targeted therapy. If the patient have a mutation, actionable mutation, we have targeted therapy for that mutation. So we live in the era of precision oncology. We're always asked to do molecular profiling of the cancer, know the cancer, that open door for clinical trials or targeted therapy beyond the chemotherapy.
Okay. Well, I want to thank our physicians so much. They have to leave us now. So you guys, thank you. Have a wonderful rest of your Saturday and weekend. Again, if we could give them some reaction, guys, some applause, some applause. And now we're going to transition and we are going to bring you a survivor and then a caregiver, and we're going to have a Q&A for them. So if we could bring Terri Milton to the stage. I'm going to quickly answer these last two questions. Jerry Jacob, I have cholangiocarcinoma. Can I still be here? Of course you can still be here. However, I do recommend you check out the Cholangiocarcinoma Foundation. They're wonderful. We work with them all the time, and it is a very different cancer, even though it is a cancer of the bile ducts. And then Rose, I have rectal cancer. My oncologist is not doing anything. I want to do Y90. Rose, Y90 is done by interventional radiologist. And so I would ask for a referral to the interventional radiologist. And I do hope that helps. I want to welcome Terri Milton to the stage. Let me pull up that bio, lady. Leading, speaking, and creating opportunities for growth have shaped Terri Milton's professional and personal journey. As a liver patient and passionate advocate, she raises awareness, educates professionals and patients, and drives meaningful change. Skilled in adult education, she thrives speaking to groups from 5 to 10,000 and developing training platforms from concept to execution. Her experience includes leading volunteer teams, managing organizations of over 200 members, and working across both nonprofit and for-profit sectors. Terri also creates social media platforms, trains and encourages volunteers, and designs content that demystifies medical terminology, thank you, empowering patients, caregivers, and families to better understand and navigate liver disease. Terri, thank you so much for joining us.
Thank you for asking me to be here.
Yeah, so we've known each other for a while, and I have to say, until I read your story, I didn't know how recent it was. So would you take us back to how your liver cancer journey began?
Definitely. Actually, as my journey started in 1998 with just a diagnosis of fatty liver that was told, just like you said earlier, don't worry about it. But my actual journey actually started in 2017 with a diagnosis that was confirmed or found during gallbladder surgery. Um, I had cirrhosis of the liver, and that was a surprise, and it was caused by something called MASH. And so once that diagnosis came up, of course, is with cirrhosis is starts all of the surveillance for all the different symptoms and everything that happens. So my surveillance actually started. My first scan was in November 2017, and it was clear. Everything was okay. In May of 2016 did another triple phase CT scan, and they
Oh,
found
it was 18, like 6 months later?
2008
I got
May of 2018,
got it.
and they found a small tumor, just a little over 1 centimeter, so very, very small, and it had classic HCC features. And so I was evaluated for transplant, even though it was too early.
Okay, so what happened after that first tumor was found? Because that seems a little scary.
It definitely was. It's not something no one ever says, "Hey, I want to sign up for this."
Right. Yeah, great.
Um, so that summer I did have a microwave ablation.
Okay.
And as by November of 2018, actually November 30th of 2018, did another scan and they found that the cancer was back. And at the same time, the doctors also found a separate tumor that was in my colon.
Oh,
So December 2nd, I had surgery that removed my cecum, part of my colon, part of my small intestines. And fortunately for me is that 3 centimeter tumor was benign.
The one in the colon.
Correct.
Oh, good.
Um,
Okay.
but I had to heal before I could even address the tumor in my liver. So the unmet need here was better coordination. There was a lot of different things I had to jump through as far as waiting and doing everything. And so there could have been a better coordination with that. I did have in February of 2019 is I did end up having a TACE.
Okay.
And so that did eradicate the tumor, but unfortunately is also caused a blood clot. And that blood clot was in my superior mesenteric vein and caused it was partially occluding, which means it was not fully blocking my vein, but it was there. So I had to go under treatment with anticoagulant. So I had to go into taking all of the blood thinners that were part of that. Um, when that
Oh,
happens, when the blood clot does happen after TACE, and that means that TACE is no longer an option.
got it.
Cannot be used again. Um, a year went by. So in April of 2020, another tumor appeared.
Mm,
And so this time is the doctor said, okay, so of course is my tumors always go before is the tumor board, and they decided to go ahead and do a tear, which is another name for it is a Y90. And so had the mapping. Within a month is after that mapping, I had severe pain, and they went ahead and they did a scan, even though it was too early to see what was going on. They went ahead and did a scan. And not only did they find that the tumor was still there, but that it had grown. In fact, it had doubled in size. And so doctors are going, okay, we don't understand. We mapped it, everything was good. So they went ahead and did another map. This time is the director of interventional radiology came in, and what he found was an unusual finding. That tumor had actually was not getting its blood supply from my liver, but was actually getting its blood supply from my kidney. So from my right kidney, it had grown a little vessel over, and that's where all the blood was coming from. Doctors decided to go ahead and go in and do a radio frequency ablation and hit it twice to make sure that it was completely obliterated. But at the same time, is because this tumor had grown so large, I was now qualified for transplant and went through transplant
thank goodness.
I know
Thank goodness. When did the transplant happen? Tell us all about that.
that was May 31st of 2022, and
Wow.
life-changing and amazing, and oh my goodness, it has been an amazing 3 years. Um, Andrea, one of the things I got to do was on June 1st of this year is to celebrate 3 years of post-transplant is I actually went skydiving.
Oh, that's awesome. I love skydiving. That's great. Where did you, we have people who are reacting that love skydiving as well. Where do you feel, what was the biggest unmet need during this journey? Because I know you have a very unusual perspective here.
Um, the biggest gap is support for caregivers. During the years that of this journey is my husband was hospitalized twice for sepsis. He lost two of his toes, is had to go into surgery because of diabetes that was advancing. And it was all because he was afraid to tell me of what was going on. Is he didn't
Oh,
want to burden me with his needs, and so he just kind of ignored everything to make sure that I was okay. Um, it becomes excruciating when you understand that, especially one of the times I almost lost him. He was in ICU for a week and a half, and had to call my kids and say, kids, you have to come because we don't know if dad's going to make it or not. And
oh
so
gosh.
the needs for patients. If the caregiver is not well, then the patient will also. There were things going on with me. I was having to go through the treatments and having to go through all of my clinical appointments, and it was hard. It was
Mm.
extremely difficult because his needs as a caregiver should have been met.
How did you navigate the emotional, mental, and physical aspects of the journey? Because this family member I referred to earlier texted me earlier in the year and said, I had no idea it would be a slog. And this person knows what I do. And I'm like, you had no idea after all the stories I've shared with you. So how did you navigate those challenges?
One of the things that I did, and it's going to sound kind of silly, but I gave myself permission to cry.
Oh.
And so one of the places that I would do that was I would go take a hot shower. And um, the deal is that either my tears dried up or the hot water ran out. Now,
Yeah,
fortunately for me,
I love that.
hot water never ran out. But there were times that everything was so overwhelming, especially in 2018, is a tumor in my colon, is tumor in my liver, is having to go through treatment for both the surgeries, is I was overwhelmed. And I was finding that I was crying all the time. I was, life didn't look very bright. And so I reached out to my doctor and I said, hey, I am in that position where I need help.
Mm.
And I think that um, were there other signs that were seen before and nobody addressed it? I don't know. But I know that fortunately for me, as I was able to verbalize, hey, I need help. And I did receive help. I received medication as I had an amazing therapist and also a life coach. It helped me to apply some of the things that I was going through in therapy. And um, so yeah, there are so many different things. I know that my husband struggled as he had friends that he could talk to. For guys, I think it's a little bit harder to
I
reach
agree.
out.
I agree. Um, I remember a patient once, he had lung cancer, and it took him a year to finally say to his doctors that he was struggling emotionally and mentally. And he had no idea the whole time the counselor was right down the hall. And but they didn't bring it up either. The physicians didn't bring it up. Here's this, and he was just amazed. It was like, oh, this was actually part of my treatment plan, just no one mentioned it to him. Um, if you could leave the audience with one message about unmet needs, and there are so many, but just one in HCC, what would it be?
Oh my goodness. There needs to be better communication between doctors. Um, During my journey, as I had so many ologists, it wasn't even funny.
Right.
And
So true.
and even though as I picked doctors that were within my same scope of um, that all used Epic, for example, they all saw my medical records.
Right.
Not all of them read my file.
Mm.
All of them would screen and look at everything beforehand. So first of all is make mental health management is part of your standard of care. I mean, that needs to be for both caregivers and for patients. It's
Mhm.
more than just a graph and a little questionnaire. Is everything okay? Because I can tell you is that once you get to the transplant, you're afraid is my mental health going to knock me off the transplant list?
Oh, that's an interesting
It
point.
is, will my mental health is prolong is my ability to be able to get treatment, you know?
Mm.
And so those are fears that we face, and they should be more than just a little questionnaire that says, hey, how are you? Because a lot of times we're going to lie and we're going to say we're great. Well,
Yeah. Oh, Terri will be back with us and shortly, and I do see people putting questions in the chat. Again, please put them in the Q&A. And Terri gave us a wonderful introduction to our next panelist, Jennifer Schumacher, A realtor broker associate, Jennifer has volunteered for several local charities over the past 18 years. Her mom, Carol, was diagnosed with HCC in 2023, and Jennifer became her primary caregiver for the next 14 months during her tenacious battle. 2.5 months into her mother's diagnosis, Jennifer was diagnosed with stage 3 kidney cancer and immediately had her kidney removed. Jennifer's cancer journey gave her unique insight as to what it's like to be both a cancer patient and a caregiver at the same time. And her mother, Carol, was a pillar of strength in life and in death. Jennifer, thank you so much for joining us.
Thanks for having me.
Jennifer was part of our Fighting Liver Cancer radio series last year, and she does have quite the unique story. So let's go back to when your mom was first diagnosed with HCC.
Yes, so she was first diagnosed in February 2023, and where we live, there's not much expertise apparently in liver care. So she was referred to the Zudi Transplant Center in Oklahoma City, which is 2 hours away from us. Her tumor was quite advanced. She was told she wasn't a transplant candidate based on her age at the time. So they did start targeted chemo or TACE. She did 2 treatments there to try to shrink her large tumor as well as some satellite tumors for a resection, since they need to get those under control before she was a candidate for resection. Yeah, she ended up having every possible side effect. And so that was a little tough. You know, ultimately since we're on the topic of unmet needs, I think it's just not having local advanced liver resources, really. I mean, it's tough when there's no specialist close to home and no guidance on support groups and next steps. They're like, okay, we're going to send you away. You have to prepare to, see all the doctors and the travel time and all that.
Yeah, no, it's Dr. Kodali mentioned transportation. It's a huge deal. How did your mom react when she got this diagnosis?
I mean, she was very surprised, as were we all. She had no risk factors, actually. She never drank, she never smoked, no cirrhosis, no diabetes, no hepatitis.
Wow.
Doctors just kept saying she was just extremely unlucky. However, she did live at Camp Lejeune during the toxic water years, and I do believe that was a major factor. Environment.
Yeah, environment is one of the factors.
And even
Yes.
though it didn't show up for decades later, but
Yep.
I do think that was a major factor. And yeah.
Were you pointed toward any patient or caregiver support groups at that time? I mean, did the doctor say, hey, Blue Faery, or American Liver Foundation, or or any organization to help you?
No, not at all. I mean, her support came from family, friends, her church family. I didn't find Blue Faery until after she passed, and that would have been a huge valuable resource. I mean, when families, the patient, the caregivers, or just people seeking information, you end up Googling things. And there's just so much misinformation out there, and it can create fear, honestly. And,
Yeah.
I mean, panic in a way sometimes. And, it'd be helpful if they would direct you to reliable organizations from the beginning, but
Some do. Some do.
yeah.
Not enough, but some do.
Yeah.
And what's so unique about your story, really, truly, is you also had your own cancer diagnosis during this time.
Yeah.
It's a solid tumor, so kidney cancer. So how did that affect things? Tell us about that.
Yeah, so after she was diagnosed and after her second TACE procedure, I don't know, maybe the next day or 2 days after I was diagnosed with kidney cancer, I was hemorrhaging, and I had a radical or open nephrectomy, so they removed my my entire right kidney with a large tumor. So it was stage 3. And so my surgery ended up being before my mom's. And I
Wow.
was, yeah, basically all of a sudden a caregiver and a patient at the same time. But I mean, as weird as it sounds, I'm glad we went through it together. It helped me have a lot more patience for her.
Oh,
And just, because I understood the extreme exhaustion and, you know, um, you
so
know,
you had your surgery, and
mhm.
then tell us then, and you said before your mom's, what was your mom's surgery like, and what was the goal of the surgery?
Yeah. So her surgery was, well, to extend her life. So
Okay.
they started off with the 2 taste procedures, and it did shrink the large tumor, so it made her a candidate for resection. Her surgeon was excellent and honest and said, gave us pretty much the details of that's a massive surgery and a huge recovery. Um, but he's he pretty much said if you want to extend your life, this is what will this is what would need to happen. Um, so yeah, she decided to proceed. She did that July of 2023, and they removed 70% of her liver, and along with the large tumor and multiple satellite tumors. Her surgeon was very blunt but caring.
Mm,
That, immediately after the surgery, when he met with me, he said, "It is not if this cancer comes back, it is when." For her
mm,
case.
yeah.
He was in there, he saw the things. So,
Right. Yeah. Yeah.
that honesty was really invaluable, and you just would appreciate it. Okay, she's gonna recover from this, and hopefully we will have time, and she set small goals to meet and be here for. And while her surgeon, I appreciated, was so open and honest with us, I definitely see a lot aren't. The system overall is lacking a lot of that, and families absolutely need more consistent and honest communication with
Right.
compassion. The compassion part is huge.
I couldn't agree more. I couldn't agree more. My the very first pediatric medical oncologist we had for my sister, and we fired him.
Yeah.
His way of telling us she was dying was, now would be a good time to take a trip to Hawaii. And I was
Jeez.
furious. I was
Yeah.
so furious. And I just want to remind people, our livers are the only internal organs that regrow. So to take 70% of the liver is a lot, but your
Yeah.
livers do grow back. I mean, they really are such amazing organs. Um, what was the hardest part about the final stage of your mother's care?
Um, so towards the very end, her cancer had spread to her lungs, and our local hospital was very, very siloed.
Mm,
So she ended up at our local hospital, and the specialist treated everything separately. No one was addressing the big picture that she had stage 4 liver cancer.
right,
And when she went to the hospital, she was not on any oxygen over several days. She needed help support with oxygen. Over a few more days, she needed 70% oxygen. So it was overtaking her lungs. We knew that, we saw that, and we just wanted somebody to address the cancer is taking over, you
right,
know?
yeah,
And she'd been on a clinical trial, and so we had to get released from that in order to get back to her regular oncologist. And when I finally talked to him and he could see all the scans, he was very honest. Well, I said, I know you don't like to give time frames, but we really need help here.
yeah,
We think we know, but I would just like an expert. And he said, it could go any which way from what I'm going to say, but I think you're looking at days to a couple weeks. And so that really helped for my mom to go, okay, that's what I thought, but now I want to enter into hospice. Just
nice.
so it empowers you with the information. Of course it's hard, but you can then make better decisions for yourself, and treat the whole person in clear communication. And, it was very frustrating when all the doctors just avoided that she had stage 4 liver cancer and basically was, we could, we knew the end was here, but
Yeah.
you just want somebody that with the knowledge to be honest.
Yeah. I think what you did was really incredible, and I want to point it out. It was you asked, right? You asked for the timeline. There are many patients that don't want to know, right? They don't want to know anything. Some much older, patients. And in that case, then that patient needs to designate the person who needs to know because somebody needs to know
Right.
what's going on. We're about to bring Terri back. I see the questions piling up. What is if you could leave one message for clinicians and families about unmet needs, what would it be? And then we'll go into the Q&A for these ladies.
Yeah. To be honest in a caring way, even when the answers are hard, just don't sugarcoat and avoid the various options and the reality of all of it, because treatment is hard and those side effects, and that just be honest with all of that, because families deserve the truth in order to prepare, and make resources and support groups available from day one. And as it's mentioned multiple times, remember the caregivers are part of the, definitely the journey, and the patient and caregiver are on that together.
Oh, I love that. As a caregiver, I really appreciate that. So Terri's coming back. Don't worry, everyone. We're going to give a quick quiz here. So, not that one, or we want the quiz, not the poll. We want the quiz, not the poll. So let's close that one out, and we want the quiz. So we just want to see if you guys have learned anything today. What do patients and caregivers most often identify as unmet needs in HCC care? Access to early screening, clear communication from providers, support for caregivers, or all of the above. And we're going to give everyone about 30 more seconds because I always believe in ending on time, and we want to get to your questions. Oh, these are great. I can't wait to share. Okay. This is fascinating. And thank you so much for all the participation. I see almost every single person here live is participating. If you're watching the replay on YouTube, you missed out. What can I say? But we're going to share this. Okay. All right. So here, let me share it. And here are the results. Let's see, 12% said access to early screening, 6% said clear communication from providers, and 82%, the majority, said all of the above. And yes, the correct answer is all of the above. Absolutely. Those are all unmet needs. So thank you so much for participating in that quiz. And if it's still on your screen, everybody just close it out. And let's go to the Q&A that we have for Terri and Jennifer. Let's see. Oh, very interesting. Okay, we're going to start with Robert. What are the physiological sensations one feels with liver cancer? Do these physiological sensations change when receiving immunotherapy? And again, only if you feel comfortable answering. I'm not sure if you had a immunotherapy, Terri, or if your mother did, Jennifer.
So physiological sensations for liver cancer, basically what they tell us is that the liver doesn't have any pain receptors, so you can't
Right.
feel anything.
That's the problem.
I can tell you this is that because the liver does swell, is it does hit underneath your rib cage, which is very sensitive. And so the pain that I felt was actually because of that. So there was a upper right abdomen. It was more than discomfort at times. There was times that it was a lot of pain, is right referred, shoulder pain. And that was actually what I usually had was pain in my right shoulder more than anything else. As far as I did not receive immunotherapy, and part of it is because my cancer was always within Milan standards, so I had localized treatment only. And for localized treatments, much like what as Jennifer's mom had, is that you are going to have pain with taste. You are going to have pain with tear. Is mine usually lasted about a month, and then it would trigger off or kind of go off a little bit. One of the things one of the nurses told me was that pain was an indication that that it was working.
Oh,
So
wow.
I cheered, is like, yes, I'm in pain. Oh no, I'm in pain.
I'm glad you brought up the right shoulder. That was one of my sister's only symptoms, was right shoulder pain. And we did not know that there's a nerve from your liver that goes to your shoulder. It's called referred pain. Don't want to scare anyone who has right shoulder pain out there. But it can happen in liver cancer, especially with advanced stages. But Terri made a really good point. The reason, if you don't know that you have underlying liver disease, or like you're Jennifer's mother and you don't have any underlying liver disease, the reason liver cancer is often diagnosed in later stages is because the liver doesn't have pain receptors. So what Terri was describing is what happened to my sister. Her liver got big enough that it pushed on her diaphragm, and she said, "I can't breathe." And that's all she kept saying over and over. And that was day one. Okay, these are great questions. Let's see, Lucy. I was found with a tumor on the upper outside part of the liver. They're suggesting radioembolization. Is this a good option or one of the best options? Now, Lucy, I'm just going to preface this that no one here are medical providers, but they can just give you their insight into radioembolization. So either one of you want to take that?
As I did have a radio frequency embolization actually in 2020, and that was what treated the last tumor that was found in my liver. It actually bridged me to transplant. So it was another 2 years, and then I had a transplant. So for me, it worked wonderfully. It was very effective.
Okay, excellent. Jennifer, anything regarding your mother you want to touch on with that?
Well, she didn't have that.
Any of that? Yeah. Okay. That's what I thought. But Lucy, always get a second opinion. And if you have trouble with that, you let us know. And Rose, this is more of a statement than a question. So, living in Florida, it's hard to get help. You are so lucky living in Texas. I'm going to say, Rose, it depends on what part of Texas, because it's a big state, just like Florida, just like California, right? And you have these areas of each one of those states where there are incredible specialists. But if you're in a rural part of Texas or Florida or the middle California, it's very, very hard. But Rose, if you are having trouble, we know a lot of providers in Florida that specialize in HCC. So please reach out to us after the webinar. Thank you so much. All right, so I don't see any other questions. If there are any other questions if they're in the chat, please put them in the Q&A. And let's go ahead now, and we are going to launch the poll. We just want to know what you're going to take away today from this program about unmet needs in HCC. So after participating in the workshop, what changes regarding liver cancer care do you plan to make within 1 to 3 months? And you can check any of these that apply. You can seek out support from Blue Faery or other patient advocacy groups. I know Terri runs several groups on Facebook. You can join a community for liver cancer patients and caregivers, such as Blue Faery's private community. You can talk to a mental health professional, big, or other healthcare provider, and read educational materials about liver cancer care. So, these are great, guys. Keep them coming. This is fantastic. I love the participation. I love the participation. So I'm going to give everybody 15 more seconds because we still have people coming in, and I'll share the answers to the poll. Again, we thank you so much for joining us. And okay, let me share the results. So it looks like you guys are going to do a lot of things, and I'm really excited to see that. But I'm going to call out the mental health professional. I'm going to call that out just because the majority of you said you would do that. And it should be part of that multidisciplinary team if you're fortunate enough to be seen at a major cancer center, but often it's a forgotten piece, that psychosocial support. You just got to ask for it. You just have to ask, and it's so important. So I just want to, first of all, I want to thank all of you for coming on a Saturday. If you showed up live, if you're watching the replay on YouTube, thank you so, so much. Robert, if you got one more question, we're running out of time, buddy. Throw it in the Q&A and we'll get to it, I promise. In the meantime, I want to acknowledge all of our sponsors. The major sponsor for this event was Genentech, and we thank them so much. Other sponsors for this program for the year include Eisai, Exelixis, and Merck. And then Aura's going to put in the chat if you want to join our private HIPAA compliant community. It is for specifically for HCC patients and families. She'll put a link to that in the chat. And also, we can't do this without you. So we are also going to put a link in the chat if you want to donate to Blue Faery. We are a nonprofit. Your gift is 100% tax deductible. Okay, there. Oh, Robert, this is great. No question. Thanks for all that you do. God bless you all. Oh, thank you so much, Robert. We appreciate you. Terri, Jennifer, Dr. Kodali, and Dr. Abdelrahim, thank you so, so much for being here today. Thank you to our amazing program manager, Aura. She's been the person in the chat telling you guys to put it in the Q&A. But we thank you so much. And if you want to see this again, it will be on our YouTube channel next week. Just give us a couple of days to get it up there. And again, I want to thank all of our panelists. You guys are just fantastic, absolutely fantastic. Oh, we got hearts. That's great. Take care. Have a wonderful Saturday. If it's still Saturday where you are, if you're in Australia, I hope you're having a great Sunday. And have a wonderful weekend, everyone. And thank you so, so much. Oh, you're welcome, Teresa. Thank you. Thank you, ladies. Take care. Bye-bye.